Hi everyone, my name is Arushi, and today I'll be presenting my honors thesis titled Resilience Profiles in Chronic Pain, the Role of Trauma Exposure and Trauma Symptoms. Before I begin, I'd like to disclose that I have no relationships, financial relationships, or any potential conflicts of interest or biases. So, chronic pain is not just a sensory experience, it is shaped by cognitive and emotional processes. Research increasingly conceptualizes chronic pain as a biopsychosocial condition where psychological factors play a key role. Importantly, pain and emotion are deeply interconnected, with emotional stress and processing influencing both how pain is perceived and how it persists over time. This highlights the need to better understand the psychological mechanisms that differentiate patient outcomes. One of the most important psychological contributors to chronic pain is trauma. Trauma exposure is highly prevalent in chronic pain population. This exposure is often associated with the development of what is known as post traumatic stress symptoms or PTSS, such as intrusive thoughts, avoidance behaviors, and hyperarousal. These emotional and physiological responses can interact with pain systems, reinforcing both distress and pain experiences over time. In fact, emotional distress and pain often have a bidirectional relationship where each amplifies the other. However, a key point is that not all individuals exposed to trauma develop significant symptoms or poorer pain outcomes. This variability highlights the role of resilience, which is defined as the ability to maintain adaptive functioning despite adversity. While resilience is well studied in general population, it remains less understood in individuals with both trauma exposure and chronic pain. Previous research has shown that trauma and chronic pain are linked, but there's limited research examining resilience within trauma exposed chronic pain populations. Specifically, we don't know how resilience profiles differ across individuals with different trauma experiences and symptom levels. This matters because if we can identify what resilient individuals in this population look like, we could use that information clinically. This could mean strengthening resilience skills in people who aren't doing as well, or even categorizing patients into different phenotypes or profiles, which can help healthcare providers tailor personalized treatments more effectively. Keeping that in mind, our main hypothesis is that trauma exposed individuals with low symptoms will demonstrate a more resilient overall profile compared to those with higher trauma symptoms. To test this, we first created a resilient and a vulnerable group based on trauma exposure and trauma symptoms. Then we looked at three domains: emotional or affective burden, clinical pain measures, and psychological resilience resources. Across these three domains, we examined 16 outcomes using self report measures to comprehensively assess differences between groups. Based on prior literature linking trauma symptoms and pain related distress, we expected the vulnerable group to show worse outcomes across these domains. Now, onto the participants and grouping. We had a total of 80 participants. The sample was predominantly female, which aligns with existing literature showing that chronic pain is more commonly reported in women. The mean age was 42 years old. Trauma exposure was measured using the brief trauma questionnaire, and trauma symptoms were assessed using the PCL-5. Using these two measures, we created three groups: a no trauma group for comparison, a resilient group with trauma exposure but low trauma symptoms, and a vulnerable group with high trauma exposure and high trauma symptoms. Group differences were analyzed using one-way ANOVAs, and outcomes included the three domains. Now, looking at the results, I'll start with emotional outcomes. Here, the vulnerable group showed significantly higher levels of anxiety, depression, depersonalization, and pain catastrophizing compared to the other groups. In contrast, the resilient group was largely comparable to the no trauma group across these measures. While these findings are expected, given that group classification was based on trauma symptoms, they help validate our grouping meaningfully and that it shows that the grouping captures differences in emotional burden. Surprisingly, for clinical pain outcomes, there were no significant differences between groups. This suggests that the key differences between groups may lie less in physical pain and more in how individuals psychologically and emotionally respond to it. Finally, we examined psychological resilience resources. We found significant group differences in optimism, coping competency, and self efficacy. The vulnerable group showed consistently lower levels across these domains, while the resilient group again closely resembled the no trauma group. So, overall, taken together, these findings suggest that it is not just trauma exposure itself, but the presence of trauma related symptoms that differentiate vulnerability in chronic pain populations. What stands out is that the most consistent differences emerged within the emotional domain, highlighting this as the central area where vulnerability manifests. In contrast, the absence of group differences in clinical pain outcomes suggests that resilience does not necessarily alter the intensity of pain, but rather how it is experienced and managed. This is further supported by the pattern seen in psychological resilience resources, where resilient individuals showed profiles similar to those with no trauma exposure, indicating a protective set of psychological characteristics. Taken together, this points towards the importance of targeting emotional and cognitive processes in treatment rather than focusing solely on pain reduction. However, there are still a couple of limitations to consider, such as the small sample size, the use of only self report measures, and additionally, resilience was inferred from related constructs rather than measured using a standardized scale. Future research should incorporate longitudinal designs, a standardized resilience measure, and potentially neurobiological approaches to better understand the underlying mechanisms. I would like to thank my supervisor and the members of the NetFest lab. Thank you.